For next presentation will be given by Dr. K Thankappan. He is professor and consultant in Head and Neck Surgical Oncology Department at Amrita Institute of Medical Sciences.
Hello everyone. Thank you for this opportunity. My topic today is salvage laryngeal surgery in pre-treated patients. What is salvage surgery? It's a surgery for loco-regional recurrences after a failed radiotherapy or a chemoradiotherapy. The standard of care in larynx, hypopharynx T1 to T3 is radiotherapy or chemoradiotherapy. And laser surgery or open partial laryngectomy may be used in early stage disease. And the rationale for using the non-surgical treatment is organ preservation. The local control rates for larynx and hypopharynx roughly vary from 60 to 95% for glottis and maybe like 88 or something like it for hypopharynx. So the recurrent or residual disease can happen in up to 50% of the patients. And what are the options? It can be salvage surgery, that's the preferred option. You can give radiation in small suitable disease with sufficient disease-free interval, and palliative treatment in very advanced and metastatic disease. The surgical salvage options could be transoral laser surgery, we heard about it, in recurrent small lesions in selected patients. Transoral robotic surgery again in small selected patients, and open partial laryngectomy in very selected patients. We all heard from them that doing this laser robotic or open partial laryngectomy in salvage situation is tricky. And so most of the cases end up in total laryngectomy, and that's what I will be concentrating in my future slides. So what are the challenges? Can be the biology of the disease, the sequelae from radiotherapy, which includes edema or fibrosis. The detection of the disease can be a challenge because of the low accuracy of conventional diagnostic modalities, and submucosal spread, especially in the case of hypopharyngeal cancer, and that can lead to underestimation of the extent. We have challenges in reconstruction. It can result in functional problems, complications, morbidity, and above all, there can be some economic implications also. Looking at the oncological outcomes, RTOG 9111 study says the overall survival is significantly lower in patients requiring salvage than overall survival for patients not requiring salvage. And recent papers are there showing the 5-year overall survival ranging from 37 to 59, and disease-specific survival from 54 to 68%. So we can get a decent survival even after doing such surgery. And most recurrences develop within first 2 postoperative years, and the median time from the recurrence is about 10 months. There are different papers that have looked into the prognostic factors for oncological outcomes, and the main among them are the disease-free interval, meaning that a delayed recurrence may mean less aggressive biology. Subsite of the disease, supraglottic may be better than glottic, may be better than hypopharynx. Prior chemoradiotherapy can be a prognostic bad predictor. Stage of the recurrent disease and severe comorbidity. We also have looked into our data. This is data for the whole head and neck cancers, about 241 patients who underwent salvage surgery, out of which 70 patients were larynx and hypopharynx. And we could prove that prior chemoradiotherapy and pathological perineural invasion predicted poor outcomes after salvage surgery. What are the indications for total laryngectomy? Recurrent T3 tumors with cricoarytenoid unit fixation, hemilarynx fixation, paraglottic, pre-epiglottic space invasion, hypopharynx and subglottic subsite. In RT4A tumors, extralaryngeal spread and cricoid cartilage infiltration. In smaller tumors, we may try for partial laryngectomy, but if the candidates are poor surgical candidates, we can try again only total laryngectomy. The surgical technique, we usually take a transverse neck crease incision. We usually take a separate stoma, thin thick skin flaps, minimal tissue dissection. Thyroid and parathyroid preservations, we are recently using near-infrared autofluorescence to identify the parathyroids and preserve them. Paratracheal nodal clearance is important, we heard about that. Cricopharyngeal myotomy is important. T-closure, cornel technique of closure, and most of them end up in a patch or an overlay flap reconstruction with PMMC, and the stoma has to be of appropriate size. Neck dissection, N+, there's no doubt we have to do a comprehensive neck dissection. N0 neck, whether a prophylactic neck dissection is indicated is the question. Overall occult metastasis rate in salvage cases is about 17%, and literature gives preference for supraglottic tumors and recurrent T3 and T4 tumors. The status of the prior neck treatment is also important if the patient has received CT-RT for T3 tumors versus just a small field RT for recurrent T1 and T2 tumors. Levels 2 to 4 bilateral and paratracheal nodes has to be seen and cleared. Now moving to reconstructive challenges in general could be like the complexity of defects, inadequacy of reconstructive choices, vessel depleted neck, fibrosis and healing issues, poor nutritional status and poor motivation. This is a paper which has looked into microvascular free tissue transfer after radiotherapy in head and neck reconstruction. But this is in general. In larynx, there's not much complexity usually, and we have a flap, pectoralis major, which is usually comes handy. So the choices are pectoralis major flap, supraclavicular flap, visceral flaps, or free flaps. In partial pharyngectomy defects where adequate mucosa is available, we can go for a pectoralis major or muscle overlay. And when the mucosa is not adequate, we may have to give a pectoralis major myocutaneous patch. In circumferential defects, where the lower stump is available in the neck, we can use tubed supraclavicular flap or a tubed pectoralis major, jejunum unusually. And when it's not available, we can have to resort to a gastric pull-up. This is a picture of a tubed supraclavicular flap. I have a video, if time permits, I will show you that. And the tubed radial forearm flap. And associated skin defects are also a problem where we can do a partial thickness skin grafting because these patients usually doesn't go for a radiation again. You can also use a DP flap or a pec major flap to cover, but this is usually the case. And it can be complex when sometimes we have resorted to bilateral pectoralis major defects in similar case of like a stomal recurrence. Again, we have looked at the reconstruction in salvage surgery for head and neck cancer. This is also general for head and neck cancers, around 193 patients, and of which 100 patients underwent free flap. Pectoralis major was the commonest flap used in 68 patients, and this series also had a decent number of larynx and hypopharyngeal cancers. TEP in salvage laryngectomy, we usually try to do it, and we do it as primary. Relative contraindications are like a bulky flap reconstructions, visceral reconstructions, and if it is associated with a total glossectomy. Complications after salvage surgery, overall complications rate is about 42 to 67%. Pharyngocutaneous fistula is about 30%, wound infections, post-op hematoma, and long-term dysphagia due to stricture is a common problem. And PMMC, there are many systematic reviews and meta-analysis which have proved efficacy, like this one or this one by Dr. Paleri, where the pooled relative risk was 0.63 and flap reconstruction reinforcement reduced the risk of pharyngocutaneous fistula by 1/3. That's what Paleri and team says is. Stricture is a problem. Skin flaps are more for developing strictures. Here's a video fluoroscopy showing a stricture. I think the video is not playing, that's fine. But you can see the stricture, and the algorithm is, if it is just a mucositis early phase, we can just give supportive care. And if it is still advanced, like a partial solar, we may require serial dilatations. And if it is a complete stricture, if it's amenable to dilatation, you can do it. But at a stage, you may have to resort to a surgical reconstruction. Again, we have looked into the pharyngoesophageal strictures. Following treatment of laryngeal and hypopharyngeal cancers, Dr. Riddhi was the first author for this paper. We had 35 strictures across 207 patients over 3 years. We divided them into 3 groups where RT-CTRT was the primary modality. Second group was total laryngectomy followed by adjuvant CTRT primary, and the third group was salvage laryngectomy post CTRT. We saw 35 cases or 16% developed post-treatment stricture, of which 68% had received CTRT with laryngectomy. The commonest site was cervical esophagus. Arkan gives a classification of sites of this stricture from oropharynx, hypopharynx, cervical esophagus, and thoracic esophagus. So our commonest site was 6 cervical esophagus. 88% were managed with dilatations alone. 11% required some sort of surgery, that can be gastric pull-up, pedicled, tubed, PMMC, supraclavicular, free flaps, or visceral reconstruction. How can we prevent complications? Mainly such surgery may have to be done in multidisciplinary setting in tertiary centers with a multidisciplinary team, including head and neck, plastic, rehabilitation, including speech and swallowing. Patient selection is important, smoking cessation is important, nutritional assessment and optimization is important. We have to correct the comorbidities, and there's something called enhanced recovery program in many UK and many Western countries. We may have to find ways to develop such recovery programs. ICU monitoring is important, early mobilization is important. Avoid immediate post-operative vomiting. We give anti-vomitics and small intermittent feeds. Prolonged antibiotics, we may have to give them for 5 days, and start oral feeds after 2 weeks. We usually do a gastrographin swallow check for leak and confirm before we remove the tube. And lastly, there are financial and economic implications too. Financial toxicity in cancer care in India, this was a systematic review from Lancet, and they say recurrent cancer is one of important factor that can lead to financial toxicity in cancer care. This is data from India. Here's a small video. I have 6 minutes probably. Let's see. This is a case of, so this was a recurrent cancer. You can see in the right arytenoid and piriform involvement. Resection was done. I just want to show the supraclavicular flap, because that's a marking for supraclavicular flap. Medial is a sternomastoid, lateral is a EJV, and the clavicle you Doppler and find the vessel, and then you mark the flap. About 9 centimeter is the diameter. Flap is being raised over the deltoid and clavicle, and then either you can deepithelize this area, or you can make an incision of the skin and pedicle it towards the area where we could Doppler it. And then you make a small tunnel, and then you start tubing the flap. You get it inside and then tube it. The lower anastomosis. That's a stoma creation. And in the deltoid area, we may have to graft it. That's the end result, and the final VFS showing the swallowing outcomes. Thank you very much.